Welcome to our IV fluid and IV sedation lesson. If you haven't seen the previous lesson that goes into our IV fluid review, then I highly recommend you watch that before we kick off this IV fluid and IV sedation, because in these crystalloids that we're about to cover, talks all about that isotonic, hypertonic, hypotonic solutions. And so it's gonna help be that basis or basics and fundamentals before we get into these fluids. So there's only so much room we can put in these bags, but we do have a lot we're gonna talk about in them. So let's jump right in. Our first fluid bag is gonna be this Normal Saline. So an abbreviation for this Normal Saline is gonna be that 0.9% NaCl or sodium chloride. What this is saying is that 0.9 grams of sodium chloride is in every 100 milliliters of sterile water. So if we see a NS little bag of 250 or a bag of 100 mLs, or we have our full liter bag, for every 100 mLs, there's a concentration of 0.9 sodium chloride. So why are we using this, and why is it the most common thing that we're going to use? It's our saline flushes. It's typically our usual hydration or liter that we're going to give our patients. Well, this is because that Normal Saline is an isotonic solution. So again, our isotonic solutions are the same solutes and concentration of our human body, our normal cells and our plasma. So when we're putting this Normal Saline in, we're not doing any kind of diluting or shifting of our fluid in or out of its vascular space. So our Normal Saline is going to increase our plasma volume. And what exactly does this mean? Well, it's going to just help us create more volume as a whole without messing up our concentration. It's going to also increase a little bit of sodium because there's sodium inside of this bag, but also our fluids, our overall fluids as well. But overall, it's going to keep that beautiful ion balance. So a great way to kick this off and compare this is by using this visual representation. So if we look here, we have a swimming pool, and this swimming pool obviously has a certain amount of water inside of it. But in order to have safe swimming conditions, we're going to need to have a certain amount of chlorine and a certain amount of water. So if we have too much water and no chlorine, then you could get sick. There could be all kinds of gross, nasty germs and bugs that are in this swimming pool. But if you have too much chlorine, then this can also be really damaging to us as well. So a safe swimming condition is going to have the appropriate chlorine and the appropriate water concentration. If this pool were to suddenly go low, or maybe let's say a whole bunch of people were cannonballing and all this water is flying out of the pool, well, because there's this great mixture of chlorine and water, then we're going to lose equal amount of water. But if we have to fill this pool back up, we don't want to fill it with just water alone. We're still going to need to account for what is the balance, or how much chlorine are we also going to have to add into this pool in order to make it safe. This is no different than our blood plasma and our cells. We have a specific amount of molecules inside of there with our electrolytes and our fluid that keeps this beautiful homeostasis that we always talk about, that normal or healthy level our body always wants to keep. And if we shift any of these ions or molecules, any of the sodium, where sodium goes, water flows, if we shift any of this in the wrong way, then we're going to mess up our own concentration. So we can think of this Normal Saline that matches the same concentration as the human body. And thankfully, this is a really great foundation for more fluids that we're about to get into. Next, we have our Lactated Ringers, and the abbreviation for this is going to be our LR. So our LR is also isotonic in nature. It's also going to be incredibly helpful for hydration, replacing any fluid loss or just getting us hydrated. It's also something that we typically use in our trauma and during surgery as well. Why is this? What makes it different than our Normal Saline? Well, this is because our LR also has not just that Normal Saline or the sodium chloride in it, but it also has potassium, calcium, and lactate as well. So this is going to help us have a little extra pick-me-up of electrolytes to keep our bodies additionally hydrated. And really, because surgery and trauma and everything else puts our bodies under so much stress, this is going to be very helpful in aiding that acid-base balance. So we're getting hydration, but we're giving a lot of those electrolytes that we could potentially be using too because of the conditions we're under. And our third fluid bag over here is going to be this Dextrose 5% in water. Its abbreviation is going to be D5W. So what exactly does that mean? Well, that's going to mean that we have 5 grams of dextrose or glucose per 100 ml. So regardless of what we have, if it's a 100 ml bag of D5W, a 250 bag of D5W, or a liter, we're going to have 5 grams of dextrose per 100 milliliters. So our D5W is a little interesting. It is isotonic when it's sitting there in that bag. However, because of the dextrose, when it's administered, our bodies actually metabolize that dextrose so quickly that it leaves a lot of free water because it's D5W in sterile water. So because of all of this free water, it is actually a hypotonic once it's administered in our body. So another thing that's important about this D5W is it actually provides 170 to 200 calories per liter. So if somebody was to need a little more nutrition, a little more energy, maybe they have some problems or conditions going on where they're malnourished, this is a great way to get some calories through your IV, because without that energy, or in certain situations, catabolism is the breakdown of muscle. So if we don't have patients that are eating food or able to digest food, they're going to be malnourished. So you might see this more in that ICU setting as well, providing those calories to our patient through an IV along with that additional hydration. And we also use this fluid in DKA. Now, why would we use dextrose? So DKA is the result of hyperglycemia or high blood sugar, right? And now why would we want to put more dextrose into somebody with DKA? Well, we don't initially. So when our patient isn't stabilized in their blood sugar per se, we have to bring that blood sugar down through insulin, right? But when we get that sugar down, we still have that whole acidotic thing going on because those ketones are lowering the acid inside of our blood. So we want to get them back to that homeostasis. Well, if we start to get that blood sugar down, and typically we do this around that 250 mark. So when we brought our patient down to around that 250, because they have to remain on that insulin drip to help correct that acidosis, we do need to give them some sugar so we don't just bottom them out or make them completely hypoglycemic. Remember that our insulin is pulling out sugar, but it's also pulling out potassium and some other things out of our cell. So this is going to be a great choice when we're getting to that point where we're still closing that Annan gap that we talk about in other videos, but we still need to provide a little bit of dextrose while they remain on that insulin drip to correct that acidosis. So what is kind of this overall difference of these bags that I've drilled into my head? Well, when we think of normal saline, we think of what? That sodium chloride that it's going to give us, and particularly that, but it's also the same as our body's concentration. When we have our LR, we remember it's providing us with a little bit more electrolytes, which is great for even better hydration with some electrolytes. And that D5W has some sugar inside of it, along with that hydration. So this brings us into our fourth bag, this 10% dextrose. So this is going to be abbreviated by, you guessed it, D10W. So this is saying we have 10 grams per 100 milliliters in our sterile water. So no matter what bag, it's going to be the 10 grams per 100 mLs. So this solution is going to be different than our 3 isotonic and hypotonic solution above. This is going to be hypertonic. So why is this going to be hypertonic if it just has more sugar than what our D5W has? Well, because our D5W has a lower concentration of solutes than our human body cells and plasma does. but our D10W actually has a higher concentration of our solutes than our human body does. So when we have a lower concentration, that's a hypotonic, that's going to cause that fluid shift and it's going to go into the cell. Think hypo, those big cells. But in a hypertonic, too much, in this case, this D10, this is also going to do a fluid shift and it's going to pull that fluid out of the cells and shrink them, and it's going to put fluid more so where we probably don't want it unless our patient condition needs to pull more fluid out of the cell. Additionally, this is going to help us raise our blood glucose. So this can be given in our severe hypoglycemia as well. And each of these bags is going to give us an additional 340 calories in this liter bag. So again, if someone's malnourished and low blood sugar, this is going to be a great calorie helper that we're adding in as well. That D5W was going to be that 170 to 200 calories, and now this one is 340 calories. Okay, so we covered our D5W, dextrose and water, our D10W, dextrose in water. So now we have our dextrose 5% in normal saline. So we are saying that we have our 5 grams per 100 mLs in our sodium chloride. So the abbreviation for this is going to be our D5NS. And if you guessed it, this is a hypertonic solution. So why would we give this fluid? Well, that's because it's going to replace calories and sodium and chloride inside the body. So we're going to have those kind of same properties that we were talking about with that D5W, where that sugar is metabolized quickly. However, because of that normal saline, it's also providing us with additional electrolytes. So this is a common concentration that's used for our medications, like our IV antibiotics when we have them in a piggyback. Oftentimes you'll find this D5NS is going to be the basis of what that antibiotic is put in. But of course, like anything that is hypertonic, we always want to make sure that we're monitoring their fluid balance. Our next fluid is going to be this dextrose 2.5 in half normal saline. So this abbreviation is going to be D2.5 half NS. So what kind of solution is this going to be? And aren't you glad that you now have RekPlay? Because we actually have an error on this side of the page. We say that this is a hypertonic solution. Well, if we think about this, this is actually incorrect. And we're so happy that we have this video to explain why and show you. On a side note, no book, no textbook is ever going to not have an error inside of it. This is just a part of life. You can Google it, you can look at the statistics, and we are no better. We're not perfect. We are nurses. Going back to the solution, this is going to be a hypotonic solution. So this is going to be a lower concentration of solutes than our human body cells and plasma. So why would we give this type of fluid? Well, we give this when we want to replace a little bit of fluid loss, have some rehydration, but also raise some of that glucose because we have that dextrose and then we have that sodium chloride as well. So let's think about this. Our D2.5, meaning 2.5 grams, are going to be in every 100 milliliters of our 0.45 sodium chloride. So we already know that our half NS is already a lower concentration, making it hypotonic. And we know that our D5 is actually a lower concentration, so our D2.5 is even less. So this is definitely a hypotonic solution. We do like to give this in post-op situations. So we're giving them a little bit of calories. We're giving them some of those sodium. We're also giving them some of that glucose. So if we think about this, we keep saying some of this stuff is really great for surgeries. Well, the reality is our patients are typically NPO. They can't eat. They haven't eaten in a little bit. Now we went and induced all this trauma to our patient. And additionally, they're probably not going to be eating much anytime soon. They're not going to be going and eating a whole steak dinner. They're probably going to just want that pudding. So this way, we're able to give them a little more adequate hydration that helps that inner fluid balance. And our next fluid bag, I think I already gave away what it is half NS. This is going to be noted as 0.45 normal saline or sodium chloride. This is a hypotonic solution. So this is going to help increase the total volume without giving too much sodium like our 0.9 NS. This is a lower concentration though of our human body like we've been talking about. We also give this in our hypernatremias. And so why would we be giving a little bit of sodium to somebody that has too much sodium? Well, if we remember, where sodium goes, water flows. Well, typically when we see someone with high sodium, they're going to have a whole lot more fluid. And this fluid is sometimes not going to be directly into our cell. And so what we're going to do is give them a little bit of this sodium to help move that fluid back into the cells so it can be easily excreted. So our kidneys, of course, are doing all this filtering and allowing us to urinate, right? Well, if we have fluid in the wrong spot, how are we going to get it to our kidneys? So we can give them this 0.45 NS in order to help actually remove some of this fluid. But we always want to remember that we don't ever want to lower someone's sodium quickly because this can actually cause a rapid shift in fluid imbalance and it can actually cause cerebral edema. So then we can have swelling or fluid going into the cells and actually increasing the ICP in our brain. And because we have this nice, beautiful skull, we don't have a lot of room for this swelling to go as if it's in our legs or ankles. So this can actually herniate our brain. So we want to make sure that when we are lowering our sodium, we're doing this slowly and typically always in the ICU. We can also use this as a PRN for our diabetics because this can also help give them a little bit more of that hydration. We don't have to worry about that dextrose being involved that will even give them any kind of bump in their sugar, but it's still giving them a little bit of that electrolyte balance. And this is also a more common fluid that we're going to give in pediatrics because this has a lower sodium content, and our adults need a higher bit of sodium where our kiddos and our peds don't need as much sodium. So this is a much better solution for them for that hydration. And our next fluid bags here, these 7, are going to be our IV sedation. Some of these can be used as a IM injection, IV injection, but we can also use these as titratable IV drugs that are in either a piggyback or in a bag, and we'll provide these to provide adequate sedation for our patients for numerous reasons. Most of these, if we're at that level where we're putting them in a titratable form of medication in these 7 bags, then we usually are going to require our patients to be intubated because essentially all of them can cause hypotension and respiratory depression. So even though there's a lot to say about each one of these drugs, we're kind of going to cover most of the basics about them. First, we have our Propofol, and this is always going to require intubation anytime you get Propofol because it severely causes respiratory depression. So with Propofol, it is contraindicated with somebody that has a soy or egg allergy. And another thing that's important about our Propofol is that we're always changing our IV tubing every 12 hours. No matter what unit they're on. So if they've been boarding in the ER for a really long time and that shift has passed, then we need to go get new tubing. So always mark on your tubing initially when you started that Propofol drip. And we're also going to monitor our triglycerides as well because this can increase them. So if we have a patient in the ICU that's been on Propofol for a while, then we're definitely going to watch those labs in addition to that condition known as PRIS or PRIS that our patients can go through, which is Propofol infusion syndrome. And we talk all about that in our neurology section. Our next fluid is going to be our Precedex. And Precedex is interesting because it doesn't actually cause respiratory depression, which can be super helpful in some instances where we need a little bit of that sedation, but we also don't have them intubated. So for example, our CWA patients that are scoring incredibly high in their alcohol withdrawal, we can sometimes utilize a Precedex drip that will just give them enough to keep them calm because in that withdrawal, they have hallucinations and they're shaking and they're tremulous and they're anxious and they feel terrible. And so this can always be something that's really helpful. We also do use it when people are intubated as well. So you always got to take caution with your Precedex drip. Sometimes in certain ICUs, we actually can use this and our patients might even be awake and intubated, but it's actually relaxing them so much that they're not having that gag reflex and they're actually able to even walk the unit with this ET tube hanging out of their mouth. It is super weird, I know, but it is a thing. Precedex though can cause hypotension and bradycardia. So of course, because this is an IV sedation med, these are going to be much higher level monitoring medications. And we talked about this in our CWA and our non-intubated patients as well. Our next bag here is going to be our ketamine drip. So this absolutely can cause respiratory depression in higher doses. It can also cause hallucinations as well. If you've ever heard of somebody being in a K-hole, that K-hole means that they are tripping out because of this ketamine. So it's actually making them disassociate. That's why you'll sometimes see those funny videos on TikTok of people kind of coming out of that K-hole and they're saying all kinds of crazy stuff. So as funny as it is, you also have to be extremely cautious. This is a sedative hypnotic drug as well. And our next fluid bag here is our morphine. So our morphine can obviously cause respiratory depression, but we also can use a morphine drip in the ortho floors or post-surgery. If somebody's having a really hard time with their pain control, we can put them on that pump to help them out and they can kind of hit the button and deliver their morphine to them every so often. Of course, it's pre-programmed, so they can only give themselves so much, but this can be really helpful for patients that can have a little more pain control, but autonomy at the same time. And with that being said, if we do have a patient that does have this pump, they usually always have a standing order for Narcan, because if our patient some reason becomes over sedated or they're losing their respiratory drive or they're just too sleepy, or we've even just given them too much, then we can always give that Narcan to help bring them out of that a little bit. Also, it's so important to remember that when you put a narcotic with a benzo, this is very dangerous. You have a very synergistic effect, and then this can actually make respiratory depression even worse. So narcotics and benzos, when combined, are dangerous. So don't forget that. Say it again with me. A narcotic and a benzo are dangerous. Our next fluid bag here is going to be our Ativan. This is that benzo we just talked about. So it does have sedating and amnesia effects. And we usually hear about Ativan being utilized if somebody is having a seizure. And we also give it whenever somebody is highly anxious. The beautiful thing about Ativan is also maybe pre-procedure, we can do this. And so it really helps them kind of forget the moment that they're even going through, having that amnesia property. And because it's a benzodiazepine, this is going to help decrease anxiety. This is also utilized for patients that have a CWA score, withdrawing from alcohol. We actually sometimes need to remember that when they have a higher CWA score, giving them more benzos is helping them. So we do want to actually calm them down. People sometimes think that just because they gave them a dose of Ativan 5 minutes ago or 10 minutes ago, it should fix their problems. No. In the case of somebody withdrawing heavily from alcohol, we never want to withhold that benzo. We want to make sure that we're giving them what they need to get through that withdrawal. And we do talk more about this in another section, but again, it's important to hit home with that and remember that we do want to make sure we're following our CWA protocols. Our next benzo is going to be our Versed. So this also has sedating and amnesia effects. So we can also use this with seizures. And this looks a lot like our Ativan that we just typed in. It is not a duplicate. This is because it is essentially the same thing. And all benzos have a reversal agent, and this is going to be that flumaxanil or romazicon. We can always use that if we have too many benzos on board. And lastly, we have our little fentanyl bag here. So this can also cause respiratory depression. A great thing about fentanyl is that we don't see any changes typically in our cardiovascular system, which is great. So we're not going to see any hypotension or bradycardia, which is always a plus because our morphine can definitely do that. And our fentanyl is obviously going to help with our pain control, and we can also use fentanyl as an additional sedation titratable med when someone's intubated. Oftentimes we'll see them maybe on a propofol drip and maybe 25 to 75 mics of fentanyl. That really just helps keep them cozy. It's also a great way to synergistically use something to keep them more calmed down when you're trying to really get them stabilized so they're not over breathing the vent, or maybe we're expecting that they are going to have a significant amount of pain that they're in. And so if that sedation isn't titrated effectively, then this fentanyl is really going to be a help to them. And because fentanyl is an opiate, we have that reversal agent of Narcan as well. This concludes our IV fluid, IV sedation lesson. I'll see you in the next one.